Hello everyone, I am Mohammed Hamama, and this is your ASCP preparation camp. In this camp, we will go through each topic on the ASCP lecture list. In today's video, we delve into the world of mature T cells and natural killer cell lymphomas, which make up roughly 10% of all lymphomas. These less common lymphomas have their unique characteristics, diagnostic challenges, and an integrated approach to diagnosis. In this video, we'll explore the key aspects you need to know about these fascinating malignancies. Let's get started. Lymphomas originating from mature T cells and natural killer, NK, cells are less prevalent compared to their B cell counterparts. These T cell and NK cell malignancies present a distinct challenge for diagnosis due to their lower incidence and unique characteristics. They tend to involve extranodal sites more frequently, making their diagnosis and management a specialized field. Mycosis fungoides, which is the most common skin lymphoma, falls under this category and exhibits a T cell phenotype. One of the major challenges in dealing with T cell lymphomas is the significant morphologic and cytologic variability within specific subtypes. Unlike B cell lymphomas with relatively specific immunophenotypic features, T cell and NK cell lymphomas have a broader spectrum of characteristics, making diagnosis a bit more complex. To overcome these diagnostic challenges, an integrated approach is essential. It combines morphologic, immunophenotypic, cytogenetic, molecular, and clinical information. Recent advancements in diagnostic methods have been quite helpful. For instance, antibody-based methods, such as flow cytometry using antibodies that target the variable region of the T cell receptor, can provide valuable insights into T cell clonality. Mycosis fungoides, a common skin lymphoma, and its more aggressive counterpart, Sézary syndrome. These conditions primarily affect the skin but can have varying presentations and outcomes. Let's explore the key aspects you need to know about mycosis fungoides and Sézary syndrome. Mycosis fungoides is a skin lymphoma that often flies under the radar. It's characterized by small to medium-sized lymphoid cells with irregular nuclei, typically found in the skin but occasionally lurking in lymph nodes. This lymphoma can manifest in various ways, from early skin infiltrates to later tumor-like lesions. Immunophenotypically, it showcases T cell markers like CD3, CD5, CD2, CD4, and a clonal T cell receptor gene rearrangement. Sézary syndrome is like mycosis fungoides on steroids. It's a more aggressive form of lymphoma that presents with widespread skin issues, known as erythroderma, lymph node swelling, and the ominous presence of circulating lymphoma cells, aptly named Sézary cells. These cells have distinct characteristics that help differentiate Sézary syndrome from its less aggressive counterpart. Mycosis fungoides primarily affects older individuals and usually has a good prognosis in its early stages, progressing slowly. On the flip side, Sézary syndrome is a whole different ballgame, with a more aggressive nature and lower survival rates, typically seen in older patients. Diagnosis is a combination of morphological and immunophenotypic evaluations, crucial for determining the right approach to management. Peripheral T-cell lymphoma, unspecified, or PTCLU, is a bit of an enigma. It's essentially a diverse group of lymphomas, each with its own distinct characteristics but lacking a specific classification. When we look at PTCLU under the microscope, we see a variety of morphologies, often featuring medium to large cells with atypical nuclei. Some variants even contain a mix of different cell types, including small lymphocytes, immunoblasts, histiocytes, and eosinophils. Bone marrow involvement is common, but circulating lymphoma cells are rare at the time of diagnosis. Most cases originate from CD4+ T cells, and there may be a loss of certain T cell antigens like CD7. PTCLU doesn't hold back when it comes to causing trouble. It's typically an aggressive disease that predominantly affects older adults. Patients may experience a variety of symptoms, including generalized lymphadenopathy, fever, night sweats, weight loss, and pancytopenia. Unfortunately, PTCLU doesn't come with great survival statistics, with a 3-year survival rate of around 40%. This is often due to advanced stage at diagnosis, biologic factors, and limited treatment options, which may involve borrowing therapies from the realm of aggressive B cell lymphomas. Anaplastic large cell lymphoma, or ALCL. This lymphoma is defined by its large atypical cells and presents unique features that set it apart. So, let's explore ALCL's distinct characteristics, from its morphology to its prognosis. Anaplastic large cell lymphoma is quite the showstopper in the lymphoma world. It's characterized by the presence of large atypical cells, boasting pleomorphic nuclei and abundant cytoplasm. The majority of cases express the CD30 antigen and ALK1 protein. This lymphoma can take on various morphological forms. It tends to efface lymph node architecture or infiltrate nodal sinuses. In some cases, the presence of fibrosis might make it resemble classical Hodgkin lymphoma. Within these ALCL cases, you'll often find hallmark cells featuring large cytoplasm and pleomorphic, kidney-shaped nuclei. While leukemic involvement is rare, it can happen, taking on the appearance of Sezary cells in the small cell variant. For a definitive diagnosis, immunophenotyping plays a crucial role. The immunophenotype of ALCL is what sets it apart. CD30 antigen and the often overexpressed ALK1 protein are defining characteristics. ALK1 is typically overexpressed due to specific gene translocations. To establish its cytotoxic T-cell origin, markers like Ti1, granzyme, and perforin come into play. Interestingly, pan-T-cell markers like CD3, CD7, and CD5 are often absent, with CD4 and CD2 being commonly expressed. CD45, a pan-hematopoietic antigen, can be found in some cases. Moreover, flow cytometry may show myeloid markers in about 50% of cases, and clonal T-cell receptor gene rearrangement can help with diagnosis if other markers are negative. Now, let's discuss ALCL's clinical features and prognosis. This lymphoma is more common in children, making up around 10 to 15% of childhood lymphomas, but it's less frequent in adults. ALCL typically presents as disseminated nodal disease with constitutional symptoms and may even involve extranodal sites, such as the skin. Importantly, the expression of ALK1 protein is a crucial prognostic factor. ALK1+ disease tends to have a more favorable prognosis compared to ALK1 disease, which shares survival rates similar to peripheral T-cell lymphoma, unspecified. Hodgkin lymphoma. It's an intriguing group of lymphoid neoplasms that can be categorized into two main types, nodular lymphocyte-predominant Hodgkin lymphoma and classical Hodgkin lymphoma. Although they share some morphological characteristics, they are recognized as biologically distinct entities, so we'll dive into each one separately. Let's start with nodular lymphocyte-predominant Hodgkin lymphoma. This one's a B-cell neoplasm with a unique twist. You'll often spot rare neoplastic cells, affectionately called popcorn cells, scattered within nodules of reactive lymphocytes. These popcorn cells are large lymphoid cells with abundant cytoplasm and multilobated nuclei. What sets them apart is their lack of conspicuous nucleoli. Immunophenotypically, these lymphocytes stem from follicle center cells, expressing B-cell markers like CD20, BCL6, and immunoglobulin chains. They don't show evidence of Epstein-Barr virus infection. The nodules also contain small B cells, T lymphocytes, and follicular dendritic cell meshworks. Clinical features and prognosis reveal that this type typically affects males in their 30s and presents with localized peripheral lymphadenopathy. Mediastinal lymph node involvement is less common. When diagnosed in the early stages, it boasts an excellent prognosis with 80% to 90% survival rates. Now, let's turn our attention to classical Hodgkin lymphoma, a group of lymphoid neoplasms originating from the germinal center. This one's characterized by the presence of relatively few diagnostic neoplastic cells, the famous Reed-Sternberg cells, surrounded by a reactive background. It's intriguing how its incidence varies by region and age. These Reed-Sternberg cells, with their bilobed or binucleate nuclei, prominent nucleoli, and abundant cytoplasm, are characteristic of classical Hodgkin lymphoma. But there are variations with other neoplastic cell variants like Hodgkin cells, mummified cells, and lacunar cells. They share a common immunophenotype, typically expressing CD30 and CD15 antigens but showing weak or absent expression of CD20 and CD45. The presence of Epstein-Barr virus, EBV, infection varies among subtypes. The background small lymphocytes are primarily CD4 plus T cells. The subtypes of classical Hodgkin lymphoma. These subtypes have distinct characteristics and morphologies, providing valuable insights for both diagnosis and treatment. Our journey begins with nodular sclerosis classical Hodgkin lymphoma, the most common subtype, accounting for 70% of cases. It's recognized by the presence of broad collagen bands within lymph nodes and thickening of the nodal capsule. Interestingly, it has a lower frequency of EBV infection. This subtype divides the lymph node with collagen bands and features small lymphocytes, eosinophils, and histiocytes. Next up, mixed cellularity classical Hodgkin lymphoma, which has a distinct appearance with Reed-Sternberg cells and variants scattered amidst a diverse background of various cell types, including small lymphocytes, histiocytes, eosinophils, neutrophils, and plasma cells. Around 20% of classical Hodgkin lymphomas fall into this category, with 75% associated with EBV infection. Now, we come to lymphocyte-rich classical Hodgkin lymphoma, characterized by scattered Reed-Sternberg cells among a background of small lymphocytes. It's intriguing because the background is less heterogeneous compared to other subtypes. Last but not least, we explore lymphocyte-depleted classical Hodgkin lymphoma. This rare variant predominantly affects immunodeficient patients. It features fewer reactive background cells, making Reed-Sternberg cells and variants more common. Most cases show evidence of EBV infection. Clinical features and prognosis. Classical Hodgkin lymphoma primarily affects young adults, with the peak incidence between 15 to 35 years. Typically, peripheral lymph nodes are involved, except in the nodular sclerosis variant, which often affects mediastinal lymph nodes. Thanks to modern treatment, combining chemotherapy and radiotherapy, cure rates of 80% to 90% are achievable, although they vary by stage, age, and symptoms. Among the subtypes, the nodular sclerosis subtype has the best prognosis, while the lymphocyte-depleted subtype is the most aggressive, particularly in HIV-positive patients. It's important to note that patients treated with combined therapy have an increased risk of secondary malignancies like lung and breast carcinomas and acute leukemia. Stay up to date with our latest videos by hitting that subscribe button and activating notifications. Be the first to know when we release new and exciting content. Don't keep all this valuable information to yourself, share this video with your friends who might find it interesting and beneficial. If you have any questions or comments, feel free to leave them down below. Until next time, take care and goodbye.